Great. Thank you for.
Right, take us away.
Yeah, thank you for this introduction. Let me share my screen first. Okay. Bear with me. Okay. All right, and I'll switch to the presentation mode. So good morning, everyone. I'm Taras Reshutuhka. I'm an addiction psychiatrist and a faculty at Queen's University with the Department of Psychiatry. Majority of my clinical work is related to addiction medicine and concurrent disorder care. I work in a variety of different settings, including emergency room, acute inpatient, acute outpatient clinics, as well as in an integrated addiction care community clinic, which is Street Health in Kingston. That's the name for the clinic. I also run a mobile clinic at the integrated care hub for homeless population who rarely ends up in a hospital, and they only go to the hospital if they pretty much needed to be admitted, quite often to ICU. So my clinical expertise kind of spans from community to hospital in different settings. So let me see how I can. Oh. All right. So I was asked to present on alcohol use disorder with the length of sort of diagnosing and managing alcohol use disorder in a context of addiction crisis that we're facing right now, and since opioid crisis was pretty much declared in 2016. But if I'm not an expert on managing addiction in a context that you work, so I truly believe that the expert on managing addiction in northern communities are on the other side of this presentation. So I welcome you to share your expertise with me. We quite often see population coming from up north for tertiary services and addiction medicine services get involved here at KGH, Kingston General Hospital. And what we notice, and my residents commented many times, that patients that come from up north, usually quite advanced in terms of their addiction, present with multiple complications of addiction in terms of physical and mental health. So I'm sure that when it comes to severity, your group up north is way more accustomed to deal with that end of spectrum than us here. But I'll try to share my expertise with you today when it comes to management of alcohol use disorder. So I have no conflict of interest. No one pays me money, but if wealthy businesses are out there, I'm happy to accept any donation and put them to work for science and addiction care in the province. So I hope that by the end of this presentation, we can learn how to recognize risky alcohol use and assess for alcohol use disorder. And we also look in the integration of management of alcohol use disorder into a nursing practice in a setting, in emergency room / community setting. So these are quite staggering facts about alcohol use disorder. If you think about all addiction, mortality related to alcohol use disorder only topped by nicotine use disorder, and together between nicotine and alcohol, about 70% of death and physical and mental complications are attributed to these two substances, and opioid are a distant third. So alcohol is associated with premature mortality, disability, motor vehicle accidents, poor functional overall, increased risk of suicide, criminal activity, also imposes specific risk of physical risk, like HIV. We don't often think about alcohol and HIV connection, but in fact, the research shows us otherwise. About 50% of Canadians consume more alcohol than our old Canadian low-risk drinking guidelines. And I'm going to use the previous Canada low-risk alcohol drinking guidelines in this presentation, and I'll share with you the concern about the new guidelines that I have. Rate of hospitalization for alcohol-related issues are 13 times higher than rate of hospitalization for opiates. This is based on some older stats, and recently the new article came out in one of the tabloid that showed that rate of alcohol use disorder when it comes to rate of admission for alcohol use disorder is about 48% when it compared to all other addictions. It's also similar to rate of hospitalization for heart attacks. So, and alcohol is a major contributor to death in Canada that represent phenomenal high number, 22% of all substance use death. Alcohol affects many organs. We won't go through it, but specific highlights recently was attributed to alcohol and cancer. So drinking 3.5 standard drinks per day, every day, increases your risk of cancer by up to 3 times when it comes to cancer of mouth, pharynx, larynx, or esophagus. It is also associated with the risk of colon, rectum, and breast cancer. You know that alcohol and pregnancy and breastfeeding are well connected, and we often educate a patient that when it comes to pregnancy and breastfeeding, there's no safe level of drinking. So let's talk about addiction first. So what is addiction? And there are many different definitions of addiction, but to put it in a straightforward terms, it's a very complex process where problematic patterns of substance use and behavior interfere with a person's life. It is a chronic disease of the brain, and it affects the reward, motivation, and memory, and how they are interconnected. Any addiction, including alcohol addiction, characterized by inability to consistently abstain from drinking, impairment in behavioral control, cravings, diminished recognition of significant problem with this behavior, and it affects individuals on every aspect of life, whether it's interpersonal, professional, or social. It also affects emotional responses that interfere with the ability for someone to lead fruitful lives. Like any other chronic conditions, alcohol often involves cycles of remission and relapses, which is not very different from any other physical chronic conditions like rheumatoid arthritis. And this is often how I explain my patients that even with the best treatment and the best efforts, relapses are possible, in trying to prepare patients to face the relapses and making sure that they're able to reach out to for help immediately and minimize the impact of that relapse. Now, why people become addicted? There's three major aspects that play a role in becoming addiction. So one of them is the actual drug. So drugs right now are quite potent, and they are marketed in a way that there's a lot of competition going on, and probably the drug suppliers are not the most honest businessmen around. So they make substances that are quite powerful when it comes to effect on physical and mental health. So any drugs that able to elicit very powerful reaction in the form of euphoria has the highest propensity to cause addiction. Think about cocaine and crystal meth. So very strong, powerful euphoric response usually are the key factor that perpetuate this continuous drug-seeking behavior. Genetic plays a role, significant role. We didn't know in the past that when it comes to neurobiology and genetics, the genes plays as powerful role in establishing the addiction as the hypertension linkage with genetics. So it's pretty much responsible for 50% of addictions. Also, the personal beliefs, quite often perceiving substances as not harmful at all, or least harmful, kind of give individual a gateway to use substances, including alcohol, in larger than socially accepted quantities. Concurrent mental health problems plays very important role. Sometimes we hear in clinics that patients self-medicate for anxiety, depression, sleep, physical pain with substances, and this is important to recognize when we think about plan management for individuals who suffer from addiction in order to prevent the relapses. Social isolation is a big factor that plays a role in establishing and perpetuating addiction, because when individuals are using substances, whether it's alcohol or opiates, they usually connect it with a peer group. So replacing social connections with AA groups or any other 12-step facilitation is a very important factor for someone who's disconnected on a social level. And environment, the last factor that plays a role in establishment of addiction, is quite important. Again, cultural beliefs, availability of substances plays a crucial role in establishing an early exposure to substances. So I will be focusing very briefly on neurobiology of addiction. So there's two parts of the brain. One that's responsible for reward. This is a ventral tegmental area. This is a red, a little bit fat dot in a area of the pons. So this is the area of the brain that project to nucleus accumbens. This is our that would be considered a reward center. So anything that increases the dopamine between ventral tegmental area, VTA, and nucleus accumbens gives a powerful, pleasurable response. So this area is stimulated when you have a great meal, time with the friends, enjoying video gaming, or using substances. And our frontal cortex, once the addiction is established, the frontal cortex responsible for this ongoing seeking of substances in order to get that reward. And while majority of medication that we have for treatment of addiction in general works on this VTA nucleus accumbens area, the psychotherapy works on the frontal cortex. That's why it is important to combine pharmacological intervention with counseling and other form of therapies that improve that inhibitory function of frontal cortex and allow individuals to reclaim control over their lives. I would briefly, I put that slide not to go through every single diagnostic criteria, but if you hear in clinic that someone's using alcohol in a large quantities and it affects their ability to control the use, experience all form of functional impairments, as well as use in harmful situations that are here on the slides in red, and presents with physical signs of addiction such as tolerance and dependence. And if the symptoms present for more than 12 months, and you only have to have 2 symptoms to diagnose alcohol use disorder, this is diagnostically, you can say that someone suffers from alcohol use disorder. Based on the number of criteria, we establish the severity of alcohol use. This is a sort of simplified version, but quite clinically useful summary of what constitutes addiction. So it's if you think about this 4C, you probably capture 10 out of 11 diagnostic criteria. So continued use despite knowledge of harmful consequences, cravings, compulsive use, and loss of control over the use. Patients often, when this 4C are explained in the clinic, are able to just simply nod if you have high suspicious of one suffering from addiction or alcohol use addiction. So how do we screen for alcohol? Quite often, individuals that you are caring for come with a lot of shame and guilt. So it's not very easy for them to disclose the nature and the quantity of the substances that they use, or alcohol in this case. They often minimize the use. I often teach my students that whatever the amount they tell you, it would be safe to multiply it by 2 to establish the true quantity, or even double it after that. So asking how much do you drink, what is your drink, how often do you drink, and what was your drinking at its worst, and for any consequences of use, specifically, troubles in a family circle, legal troubles, would be able to paint a quite good picture of how severe someone's alcohol use is. Specifically clarify what they would consider the drink, because we all professionals, we know what the standard drink is like. But I recall visiting one of the geriatric patients in a community for the assessment, and he says, I only drink one drink per day. But when I asked him to clarify what the drink was, it was one of those mug people take to vacation down south to Caribbeans. It was probably close to half a liter, and he put 2 cubes of ice, and the rest tops it up with rum. So one drink does not necessarily means one drink that we think. Now, collateral information is extremely important. This is where you get clarity about that, or get around that minimizing. when patient presents and have hard time to disclose amount they drink. Now, I want to spend a couple of minutes talking about low-risk drinking guidelines. These drinking guidelines were developed in 2018 and were used up to 2023 until the new safe drinking guidelines came out. With new drinking guidelines, safe drinking guidelines, anything that is above 2 drinks per week for men and women constitutes higher risk. But clinically, it's very difficult to work using harm reduction model if anything above 2 drinks is a high risk. So majority of people who consume alcohol would be way above that safe drinking guidelines. So I still use our low risk drinking guidelines, specifically trying to work with the patients as they trying to decrease the amount they drink. We know that model of abstinence works only for about 10% of the patients, and harm reduction is a current focus when it comes to addiction care. Screening for alcohol use, there's no specific signs other than, well, I don't think there are signs that or symptoms that are 100% sensitive and specific for alcohol use disorder, including the if you put them all together. But you can get a very good history looking at repeated absences from work, frequent trauma, accidental injury, comorbid depression and anxiety, problems with sleep, sexual function, concurrent substance use. When you think about the alcohols, like individuals who use stimulants quite often combine it with alcohol. Physical findings are very limited and non-specific as well. Sometimes you won't be able to appreciate alcohol odor, but things like tremor, evidence of cirrhosis, or history of acute pancreatitis could be suggestive of alcohol use disorder. On lab finding microcytic anemia, elevated liver function test, specifically GGT, would be highly suggestive of alcohol use disorder. When you assess individuals who present with for drinking concern, think about risk assessment. And this risk assessment goes beyond what we often see in emergency room when we assess risk for suicide, violence, and self-care. Suicide and violence certainly has much higher prevalence in individuals who drink. But don't forget to screen for impaired driving, because there's a specific reporting requirements exist for us as a healthcare professionals. Think about CAS involvement and proneness to trauma. Often individuals who suffer from addiction, they are victims of trauma rather than instigators. And the other specific risk to keep in mind is severe withdrawal symptoms. For alcohol, majority of acute mortality comes from alcohol withdrawal seizure and delirium tremens when untreated. And this is 2 states that could be easily reversed. Alcohol.
Sorry to interrupt. There's a question in the chat asking about any suggestions for estimating in our setting where clients often drink homebrew, so they report in terms of jugs or cups or liters. How would you suggest that nurses would document that or estimate current usage?
You know, this is very interesting and unique question. I don't think I've been asked that ever, but again, this is what is relevant to your setting. I think majority of patients that produce homebrew, they would know the amount of alcohol in a percentage they would that they produce, or have some ideas about what's the percentage of alcohol, and they would consume, and the volume. So you could document the percentage and the volume that they consume, calculating the pure ethanol that consumed by individuals on a daily basis. And often daily drinking, like how often they drink, is also important. Like individuals who tend to drink every day obviously suffer from, in majority of the cases, from more severe substance use disorder, alcohol use disorder, than those who have occasional days that they don't drink, unless we're dealing with the binge drinkers who drink extremely high volumes on on the weekends or a couple of days per week. So even with known alcohol like purchased from licensed stores, it's always a bit of a guessing game, because of that phenomenon of minimizing, and quite often when individuals get intoxicated, they have no idea how many extra drink they consumed after that. So I don't spend that much time specifically focusing on the amount, but rather focus on how often they drink and to what are the consequences of their substance uses. But this is a great question. I didn't expect that. Did I answer the question?
That's perfect. Thank you.
So when it comes to alcohol, other than physical comorbidities such as hepatitis, acute pancreatitis, think about mental health, screening for mental health conditions such as depression and anxiety, conditions like social anxiety disorders, and post-traumatic stress disorder. They're comorbid with alcohol in about 50%. So and often the drinking becomes the first remedy for their anxiety related to social settings, or remedy to overcome traumatic re-experiencing. History of depression is also quite high in individuals who have substance use disorder, and now we know that this condition needs to be addressed simultaneously. I teach my residents and remind them that those advices to stop your drinking, your depression gets better, or anxiety will resolve, they are useless. They don't work, and we know that unless it's targeted from both ends, we have a really hard time to reach any meaningful stability. And if you have an untreated anxiety, as someone is putting the best foot forward trying to recover, that anxiety or depression or insomnia will affect the ability to maintain that abstinence, and quite often it leads to relapse. So screen for underlying psychiatric disorder. This is a single alcohol screening questions that you could use. It's has been validated and it's quite sensitive to elicit problematic drinking. There are some questionnaires that you can use in your emergency room or outpatient ambulatory settings, such as Audit C. You can, instead of doing it with the patients, I would suggest you consider providing these questionnaires to patients while they're waiting for your appointment, and you could review that after the patient's left or with the patient, and attach it to their chart. So I'm assuming that many of you work in acute medical setting and quite often deal with alcohol intoxication and withdrawal. So the signs of intoxications and withdrawals are listed here. But while management of intoxication is quite supportive, what we need to sort of stress on here is to management of alcohol withdrawal. So alcohol withdrawals is potentially lethal. When you suspect someone presenting to you in alcohol withdrawal or anticipate that someone will be in alcohol withdrawal, like individuals get in custody of police, for instance, and they have no access to drinking. They quite often, we in Kingston, we have a number of provincial and federal penitentiaries here, and sometimes patients are brought to the hospital because they had alcohol withdrawal seizure or delirium in custody. Assessing alcohol withdrawal, so think about the volume of alcohol, how often they drink, whether they have a symptoms of alcohol withdrawal like hands tremor, sweating, and require that first drink in the morning. This would be highly suggestive of impeding withdrawal. History of alcohol withdrawal seizures and confusions that suggestive of delirium tremens. Very important part of history to elicit. Even if they had abstinence for 20 years, there's that phenomenon that we call kindling phenomenon. So basically, if any individual experience history of alcohol withdrawal seizure or delirium tremens with relapse, they tend to, or they are prone to develop alcohol withdrawal seizure and DT again. So that guides your management and would require larger volume of benzodiazepines like diazepam and lorazepam to be administered. I just want to ask you whether in your setting you rely on standardized protocol, like pre-printed protocol for benzodiazepine administration. Can anyone talk?
We do have an order set for acute alcohol withdrawal. Most often, as nurses, we will assess the client and then consult the physician or NP on call. And then we will initiate the protocol based on their CWAS score.
Okay, great. So we do the same here in Kingston. So individuals who present with so CWAS protocol initiated usually immediately as soon as we have a suspicion of alcohol withdrawal or impeding alcohol withdrawals, and depends on a day. When they present to emergency room, like for instance, the withdrawals usually start after 4 hours from the last drink. So the time of the last drink is very important, and the severity of withdrawal will build up over the first sort of 24 hours, and the day 1 to 3, this is where you have a highest risk of seizures to occur. And delirium tremens can happen anywhere from day 1 to day 7. So if someone becomes disoriented and confused in your differential diagnosis, think about delirium. And this is one type of delirium where benzodiazepines actually indicated and the mainstay of treatment. In general, we all know that if patients get delirious, we try to limit the sedatives and stop sedatives for the time of to treat that delirium, but not in alcohol related delirium, which is delirium tremens. So since you guys are all professionals in CWA, we won't go through this specifically, but I just want to raise your attention to the first and early and most reliable signs of alcohol withdrawal, which is tremor, and then think about screening for previous history of alcohol withdrawal seizures and delirium tremens, because that would indicate jumping straight to the loading dose of benzodiazepines. Unless you know that history, you wouldn't be able to make that judgment call. Again, the reason I put that slide in, I want you to keep in mind that neuroleptics such as haloperidol, for agitated patients that might present and be at risk for alcohol withdrawal, is rather contraindicated because it's lower seizure threshold. So individuals who present agitated and with alcohol intoxication or agitated as a result of withdrawals, think about high doses of benzodiazepines. And anyone who has history of liver impairment such as hepatitis C or liver cirrhosis, short-acting benzodiazepines such as lorazepam is preferred over diazepam, which is a long-acting one. And treating alcohol withdrawal, usually it's already included on standard protocol. Think about thiamine, but quite often no folic acid or magnesium are the part of this standard order set. So individuals who have chronic drinking, they are prone to develop low magnesium levels, and in some studies it shows that it interferes with recovery, and folic acid needs to be replaced as well. Wernicke-Korsakoff, you all remember from your college days. It's a two specific condition that are caused by thiamine or vitamin B1 deficiency. So usually that happens when someone has a history, significant history, usually years of severe drinking. So Wernicke's triad, nystagmus, ataxia, and delirium. And many patients who have a lengthy history of alcohol abuse have this quite specific wide-based gait that you often observe. So that should also be assessed during your physical exam. So Wernicke's triad is pretty much alcohol-induced encephalopathy. And if progresses, individual will develop Korsakoff syndrome, that in addition to the three symptoms above, amnesia and cognitive deficits will emerge in clinical picture. The treatment of Wernicke-Korsakoff is mega doses of thiamine, usually IV thiamine. Our neurologist here in Kingston like to give 500 to 1,000 milligrams of thiamine by IV drip per day for patients who suspected to have Wernicke-Korsakoff. Korsakoff generally considered irreversible, but about 20% of Korsakoff syndrome can be reversed with high doses of thiamine. This is the alcohol biomarkers that usually measure the impact of long-term drinking and would be not useful in measurement of relapse. I want to also make one point about the doses of benzodiazepine when managing alcohol withdrawal. Sometimes I get a call from our teams and nursing staff that we already gave individuals 260 milligrams of diazepam, and individuals in withdrawal still scoring 20 plus on SIVA protocol. It all relates to the tolerance. So the individuals who consume 60 ounces of hard liquor per day, they would require that or higher doses of diazepam in order to overcome the withdrawal. So pay attention to symptoms more than to the actual amount of diazepam or lorazepam given to the patient. This slide shows at-risk drinking approach. So depends how patient presents to you and where they are at their stage of change. you really want to tailor that approach to patients' stage of change. So if someone's saying that alcohol isn't a problem and they could stop it on its own, and you probably heard it multiple times, sort of forcing intervention on individuals at that time would probably be very ineffective. And even if they agree to take some medication or agree to take to accept referral to counseling, the likelihood of them going and pursuing this interventions are slim to none. So in this circumstances, basically, sharing your concerns about drinking, risky drinking, educating them about physical and mental health impact of their alcohol use, and providing them with the information where they can seek treatment, sort of constitutes your intervention. Quite often, your cart with the addiction counseling resource, or them knowing that there are medications that can reduce cravings, would be very useful if they decide to make that change, but you're not around to help them with that change. So quite often in our outpatient clinic, we get patients who just simply walking in saying like, I learned about this resource last time I was in the emergency room. I'm at the point that I have to make a change in my life. Otherwise, I'm going to lose my family, or I'm going to die. So
we have a couple questions in the chat.
Yes.
If that's okay. Number
Please.
one is from Veronica and NP. Should we be giving thiamine supplementation to clients who have alcohol use disorder?
Absolutely. That should be your standard prescription. You cannot do any harm with thiamine, but you can actually prevent this terrible consequences, which is Wernicke-Korsakoff's. And individuals who drink who drinks chronically in high volumes, alcohol becomes their balanced meal. This is the nutrients that they are getting most of the time, high in calories, so their nutrition is usually very, very poor. That's why the standard for replacement would be thiamine. That's the top on the list, and then thiamine and multivitamins or magnesium supplements.
Thank you. Next question is, with such a shortage of counselors and therapists in our area, what would be your suggestion on how to manage these clients?
We face same problems, and usually if there are counselors, the wait lists are very long, or individuals are not able to afford any prorated payment or private counseling. So there are resources put in place by province. One of them, there's an online program. It's called Breaking Bad. It's a free to register, and individuals would get access to self-guided CBT based structured relapse prevention. Last time I looked, bounce back counseling is still offered to patients in Ontario. There's some restriction when it comes to substance use or severity of substance use, and on the horizon, Ontario structured psychotherapy would provide individual virtual counseling to patients with mild to moderate addictions. When it comes to severe addiction, usually that becomes a bit of a challenge. Another useful factor for patients, and we learned that it works quite well during COVID times, any AA connections would be probably where I would start if I would work in a remote community with limited access to counseling, because majority of even in remote communities, people have access to internet, and they could join AA or 12-step facilitation like smart recovery groups quite easily. And are there any other questions?
No, that's it. Thanks.
Okay, thanks. So treatment of alcohol use disorder, we usually approach as with the model of chronic disease management, and we try to focus on integrative care approach. We keep in mind harm reduction. So as I mentioned, abstinence is not an attainable goal for 9 out of 10 patients, and reducing harm of alcohol or any other substances would be the place where we often start for someone who's motivated to make change. Connecting with AA and Smart Recovery, 12-step groups, and counseling is something to consider, specifically for those who are rather on the fence or pre-contemplative about making the change in regards to the drinking. Thinking about mitigating psychiatric and medical complications of alcohol use should be always kept in mind. And we do have a very useful anti-craving medication specifically for alcohol. Unfortunately, we are under-prescribing this medication, and they do work. In one of the American studies that I came across, only about 2% of patients who suffer from alcohol use disorder were offered anti-craving medications. And they've proven to be quite efficacious, and recently, I believe in 2018, they've been added to ODB formulary, so they are covered. And I'm talking about naltrexone and acamprosate specifically. So if you we'll talk about naltrexone and acamprosate, but I briefly want to discuss stages of change and non-pharmacological intervention. As I mentioned, medication should not be used to manage alcohol addictions alone, and it's always adjunctive to psychotherapeutic interventions. So evidence-based interventions that work for addiction, specifically alcohol use disorder, are motivational enhancement therapy, cognitive behavioral therapy, 12-step programs like AA and AA, and contingency management as well has quite a useful role. So quite often when we meet patients with alcohol use disorder or high suspicion of alcohol use disorder, I find that we engage in a bit of a tug of war. Like when you're trying to say that this is harmful, the patients, on the other hand, trying to minimize it. So I often say, well, it sounds like you're quite comfortable with using that amount of alcohol for now. Maybe you should continue that way. And quite often I get the opposite resistance. So I said, well, doctor, I came to you and asked for help, and now you're telling me that I'm okay to drink. So trying to be very neutral in making that decision, but also empathetic and supportive with the patient gets you way further ahead, rather than sort of be very prescriptive in providing any intervention, whether psychotherapeutic or medical. So 2 medications that are first line for treatment of alcohol use disorder, naltrexone and acamprosate. I'll focus on those 2 because you probably will see them prescribed most often by a physician and NP. I often, if I practice in communities with limited access to addiction psychiatrist or addiction medicine specialist, when I see patients in Emerge, I give them a prescription of naltrexone for a year, as long as there is no contraindication. These 2 medications, naltrexone and acamprosate, are very clean, so to speak, from side effects. They don't cause sedation, weight gain. They're safe in overdose. They don't have any impact on sexual function, unlike majority of psychiatric medications. So patients tend to stay on this medication for once they start them. And proper education around naltrexone and acamprosate is that often patients present, they think that every medication should work like Tylenol. So telling them that naltrexone actually works by stopping you to drink too much or reduces the craving so you don't pick up that first drink. But if you don't interact with alcohol, you don't feel any effect of it. So when you decide to drink, don't stop naltrexone, because this is the time when it's working actually. So I'm going to let you review the slides outside of this presentation, but it's very easy to prescribe naltrexone specifically because it's taken once a day, usually takes with food before bedtime. The only interaction to consider would be interaction with opiates. So any patients who takes street opiates or prescribed opiates, naltrexone would send them in automatic withdrawal. You will have very unhappy patients in your clinic or in your emergency room. So screen for opioid use disorder, which is concurrent, or any opioid prescription. It doesn't require pre-treatment workup, but ideally you want to know the individual's liver function, and there is a small risk of naltrexone causing toxic hepatitis, very rare but possible. So after you initiate or someone initiate naltrexone, make sure they had LFT completed in 2-3 months. At times, even for patients with severe liver cirrhosis, when I talk to my hepatologist here in Kingston, and patients continue to drink, the message that I get from hepatologists that naltrexone, if anything, can only help, but alcohol will probably have way more toxic impact on their liver than naltrexone will. So it's relatively straightforward to prescribe and monitor. Now, when it comes to acamprosate, the efficacy is about the same, but 3 times daily administration is a bit of a challenge for the patients. So for that reason, we do prefer naltrexone as a first line medication, even in a first line group. So educating about anti-craving medications' role in addition to psychotherapy would be very, very important for the patients who are trying to achieve abstinence or reduce their drinking. A few slides with medication that are often co-prescribed. So benzodiazepines have no role in treatment of alcohol use disorder outside of managing withdrawal. So if someone requires benzodiazepines for other reasons like panic disorder, think about that compounding effect with alcohol. I often call benzodiazepines a dry martini. They hit the same GABA receptors, potentiate impact of alcohol, and can put someone at risk to develop sedative addictions. Antidepressants alone should not be used for treatment of alcohol use disorder, but quite often they are prescribed for comorbid anxiety and depression. And among all antidepressants, be cautious around use of Cymbalta, that is, or duloxetine, that is often prescribed for chronic pain. So duloxetine has a black box warning related to liver toxicity, so it can cause toxic liver necrosis. So any compromised liver function, whether it's related to alcohol or hepatitis, should sway you away from using duloxetine. And antipsychotics have no role in treatment of alcohol use disorder, and they should be avoided when you think about managing agitation in acute care setting because of the risk of lowering seizure threshold for someone who might develop alcohol withdrawal seizures. So there's a few resources that you might find helpful, and I think this is the end of my presentation. We have 5 minutes for questions. So if there are any, I'm happy to stick around even past this 5 minutes to answer them.
So I missed one on the last round when you asked if there were any questions. So there was a question, could you comment on diazepam versus lorazepam? And are benzos safe to use if concurrent active substance use?
So lorazepam and diazepam in the context of alcohol withdrawal management?
I think that's where we were at when the question came in. I don't know, Abida, if you want to clarify.
Yeah.
Yes, that's right.
So
for alcohol withdrawal, yeah.
okay, so both medications have utility, and diazepam would be my preferred option because of the long half-life. Diazepam would the individual's body naturally taper diazepam off and provide better coverage for alcohol withdrawal symptoms. So diazepam would be preferred choice in majority of the alcohol withdrawal cases. The only preferences for lorazepam would be patients with compromised liver function, because diazepam requires liver to convert to an active metabolite, and if you use diazepam for someone who has a compromised liver function, it's very easy to sort of over-sedate and sort of overshoot the management of withdrawals. Now you'll be dealing with sort of sedation related to benzo use. Lorazepam is a short-acting benzodiazepine that does not have to go through liver to act. So it would be safer in this category of patients. The downside of lorazepam that you always behind under treating their alcohol withdrawal symptoms. But on a CEWA protocol that is being administered every hour, that risk is usually insignificant.
Okay, and 2 questions here. What if someone already has elevated LFTs prior to starting naltrexone? Is the first part. And the second is, does someone have to be completely abstinent for acamprosate to start it?
Great questions. And I should have addressed them when we were talking about naltrexone and acamprosate. So I would be, if LFTs are elevated less than 3 times, I would still consider naltrexone to start. If they are absolutely through the roof, like more than 3-4 times, I would not consider using naltrexone as my first line, but I would go to acamprosate. And then when it comes to acamprosate, theoretically, the reason acamprosate is ideal to start if someone's 4 to 7 days abstinent, because it theoretically can precipitate alcohol withdrawal. So we often consider starting acamprosate for someone who's already on a unit, their withdrawal inpatient unit, or the withdrawal was managed, or they go to detox center. In Kingston, we have a non-medical detox. Then we would give individuals a prescription to start taking it after 3 or 4 days. They are out of kind of daily drinking. Often I prescribe acamprosate even for those who don't have a history of serious withdrawals like seizure or delirium. I would still, and there are contraindications for naltrexone, like concurrent opioid use. I would prescribe acamprosate even when they're drinking. I mean, less than ideal, but that it's basically on a kind of choosing between two evils. Okay.
Perfect. The last question was just about the resources, but the slides will be up on the MSERS website for anyone who wants to look at the resource slide. So any final questions? I think we are 1 minute past.
I do have a quick question.
Okay, go ahead.
Yes, please.
So in terms of the timing when they come in, most of the protocols that we have 100 milligrams of thiamine, but I was told that, like, especially if the patient is not going to come back, they've been drinking for a few weeks or so, we could potentially give like a 200 milligram dose instead, or probably even higher, for that one-time shot while we have them in our in our clinics or emerge. Is that okay to do? Because I'm hearing that it doesn't cause no harm.
Yeah, it will cause no harm. The only benefits there are only benefits to thiamine. As I mentioned, our neurologists often would consider like 500 IV 3 times per day for those individuals, and you could depends on the time you will be looking after these individuals. You would go as much as you can on thiamine. Discharge dose should be 100 milligrams daily, and often patients say, "Oh, I actually have multivitamins, so there's thiamine in it. I checked." For the multivitamins, they usually only have a half a dose of thiamine. Usually it's 50 milligrams instead of 100. So make sure that they're aware of that. So to take separate thiamine, even to the multivitamin pill.
Okay, thank you.
Perfect.
I have questions. I have a question for you if there's no other questions for the group. In your clinical setting, what is the number one substance that you have to deal with on a kind of daily basis? Will it be majority alcohol?
I see one
I think-
alcohol in the chat.
Suboxone maybe as well.
Opiates, right?
A lot of clients come in with use of home brew.
Okay. Yeah. Well, the homebrew presents with unique, unpleasant sort of fact that the commercial brew would not present with, because because of the sort of clarity of the alcohol. It could be homebrew usually quite more toxic when it comes to impact on liver and pancreas. So I'm sure that you would see a lot of toxic hepatitis and pancreatitis. The rate of substance use up north is staggering. Like, I recently came across the data that showed that opioid death rate in province was around 17 deaths per 100,000, while in 5 biggest northern cities in Ontario, that rate was 60 per 100,000. So I think the alcohol probably have a similar statistics.
Thank you very much. We appreciate you taking the time. Just a
It was
reminder to all those in attendance. Sorry. Just a reminder to all you in attendance, the last slide has if you haven't clicked on the code at the end to go to the evaluation form, we would appreciate that. We can't continue to do these without you completing the evaluations. And thank you to all the nurses for taking the time to come out this morning.
Thank you for your comments. thank you for your comments in the chat. We also struggling with crystal mass and speed here in Kingston, which is I think bigger pandemic than opioids. Well, have everyone. I wish everyone to have a great day, and thank you for inviting me to speak to your group.
Thank you so much for your time.
Bye bye.
Bye bye.